This is another hot topic, explosive anger. Anger is a easily conditioned behavior. What the heck does that mean? It means anger works. If I go to my boss and I say, I'm pretty upset with what, happened, and, I think you need to do something, and I mean it. This is pretty upsetting to me. And my boss says, okay, I'll handle that. I just got rewarded for using my anger in interaction. Happens between spouses. Anger sometimes gets flowers. I have seen where anger also sometimes breeds a greater intimacy. Those are complicated couples, because they have this makeup thing. So sometimes they pick a fight in order to make up. Anyway, it is a easily conditioned behavior. All the studies suggest that it comes from affective dysregulation. So whether it's anxiety disorders or depression or even bipolar disorder, that's where the action is. It's not a tic-related thing. It's the comorbid condition thing. Once it gets started, it gets going. And it's really because anger works. Anger shapes the expectations of other people. The problem in the United States is we love anger. We love harsh dialogue. We like getting it off our chest. We like telling it like it is. We like, being straight and honest. There are movements now to kind of restore civility to some of our discourse. But people like it when somebody else expresses their anger for them. And so we live in a culture that actually supports anger expression. So when we see kids who have tic disorders and rage or explosive outbursts, I'm looking for anxiety and depression, ADHD, so things that dysregulate mood and anxiety and impulse control. But then I am looking for really what are the triggers and the consequences of the anger episodes. Now, many families will present with chronic history of explosive outbursts, such that the explosive outbursts begin to look autonomous. They happen for no reason at all. Except that when I begin to look and do my own behavior analysis of it, those things are often triggered around transition times. They're triggered around kids' expectations that the parents are going to ask them to do something shortly. So it's not surprising that anger episodes happen before it's time to sit down for homework, for example, and appear to be out of the blue, because an anger episode prior to starting homework is going to change the parent's expectation around doing the homework. Does that make sense? If the anger episode results in the parent beginning to write a note to the teacher saying, his Tourette was really bad last night and he couldn't complete his homework, please excuse him from that homework, you now have anger facilitating the reduction in academic expectations. Does that make sense? So that's what I mean. It's easily conditioned. It works interpersonally, but it even works in terms of kids' function, and it becomes not a conscious strategy. No kid ever does this on purpose. But if the consequences are right, it sets the youngster up to get into a repetitive use of anger to manage life situations. Does that make sense? I mean, you all have had coworkers or friends where you just see them using emotional upset as a strategy to navigate through life. If they get upset about something, people around them begin to shift and change and make adaptations and kind of make it easier for them and cut them special slack or whatever. And that process, while it is natural, human, and intuitive, it is also rewarding that behavior and almost guaranteeing that it's going to persist and maybe even get worse over time. So I think it's there's a neurobiology to it, but like everything we've talked about today that's got a neurobiology, there's an important behavior and functional component to it too. Treatment, lumpers versus splitters. If you haven't figured it out by now, I am a splitter. I'm carving it up into its pieces, trying to figure out what all the other parts are. But I understand why people lump. It's just easier to communicate when you lump. So I think about tic suppression as a particular treatment focus, comorbid conditions being a treatment focus. I think about how to raise a child with Tourette's syndrome, care and feeding, if you will, which is a lot what we're talking about today. And then for adults, really learning how to overcome a chronic condition. These are kind of heroic strategies that need to be kind of part of any kind of treatment effort. So I make a list of problems or diagnoses. I rank them in order of impairment. I treat the diagnosis in order of impairment. I use treatment specific to each diagnosis independent of tics. There are some docs who will say, well, if your tics get better, your mood will improve. So I'm going to go after tics. Well, if the mood disturbance was related to tic severity, that's a reasonable thing. But if the mood disturbance was independent of tic severity, I wouldn't necessarily expect that to happen. So that's where the diagnostician's got to sort, is that mood dependent upon tic severity, like demoralization, or is that really a major depressive episode that requires independent attention and treatment? Doctors specializing in other diagnoses may be more helpful. So if you're 28 years old and you got recurrent depression or drug addiction, you probably don't need to see a Tourette doctor. And the goal is, forgive me, but fix those other diagnoses. Restore people, if you will, as completely and wholly to real functional capacity. So I would do OCD, and I would be using meds and behavioral treatment for that. I would be doing parent management training for behavior issues, and I might be using medicine, but right now I'd be using behavioral treatment. I ran into a lady in the elevator whose son really did well with the OCD treatment for the behavioral treatment for OCD and hasn't had this yet. And it worked for the OCD, but it didn't necessarily work for the tics. So there are some specific differences between the behavior treatment for tics and the behavior treatment for OCD. So sometimes you need to adapt the skills a little bit to be able to cover all these different bases. So CBT, what I said, parent behavior management treatment or behavioral. Lumpers see TS as the overarching disorder. They use this as the kind of calling card that explains everything simply. All problems in TS are TS related. I don't think we're quite there now, although there is something about conditions of the brain that always seem to impact motor movement, cognition, affect regulation, and so there's this kind of little triad of symptoms that do seem to clump together, and Tourette is one of those conditions. And the focus of these folks tends to be on the tics, and then the other kind of problems will take care of themselves downstream. This isn't my style, but these people are out there. They see a tic, they'll treat the tic, and then you kind of raise concerns about other issues, and they'll refer you out to somebody else to get that done, as opposed to hierarching and organizing what's the most impairing and going in that direction. Okay. The value of lumping is your kid's got one label. When you go to a school and you say, well, he has TS, ADHD, executive dysfunction, learning disability, obsessive compulsive disorder, and we're currently worrying about whether he has early onset bipolar disorder, the teachers glaze and are gone. And that explanation also discredits you as a reporter. Because, like it or not, when you start tossing stuff like that as teachers, it usually comes with some expectation that the teachers are going to have to manage all that. And the last thing teachers want to do is manage that stuff. They're not trained to do it. Or they think that that's the prelude explanation to you beginning to ask for special accommodations, and they really have trouble doing special accommodations. It's hard for them to individualize. So just saying it's Tourette, and that Tourette has these multiple manifestations, that's the strategy that most folks use for schools, and I'm okay with that. It's just that it's not a good strategy for me to use to get kids and adolescents and adults functioning at their very best. For that, I use the splitting strategy. I chop it up into the various components and then develop a holistic treatment approach. So tic suppression, clonidine, guanfacine, these are the alpha agonists. This is what most docs start with. I call these small because a small percentage of people respond, and often with small benefit. So many docs like starting here because they're not going to do much harm. I'm not a big fan of these medicines because you don't get many kids better with them. And in my relationship with the families that I work with, if I use a medicine where I kind of know ahead of time that it's not going to be very effective, I know that when we have a failure of that youngster to respond to a medicine that I know is not going to work, I am going to have to remoralize that family to try something else. Because every time a family tries an intervention and it doesn't work, they get demoralized. They feel like they're one step closer to that end point where they will have no options. So I'm extremely careful about managing my medication treatment trials because if I don't manage them well and parents get demoralized, they essentially fall out of treatment. 2 studies now, the anxiety disorders treatment for kids and the teen depression study, demonstrate that if people get better with anxiety or depression early in treatment, they will pursue additional treatment. If they don't get better early in treatment, they drop out. So if you engage with a practitioner and you use strategies that are safe and easy, but they don't necessarily work very often, you run the risk of getting demoralized in that context of trying something. I just heard in the break about tried this, tried this, tried this, tried this, tried this, tried this, tried this. You know, the expression that you hear is one of demoralization. People feel like they're at the end of the line, and it also discredits us because it looks like we don't know what we're doing, that we're just kind of tossing stuff. And that's an experience. When I get in the consultation clinic, I get a patient and family that's been through that. I got to do a lot of work just to get them feeling good about being back in care again. So I'm very careful about how I do these early treatment trials. These are not benign. Treatment failures really require additional management. So just be careful. Doesn't mean you shouldn't try them. It just means that you've got to find a way when it doesn't work like you expected that you can get yourself back on track. These are not commonly used. These are tricyclic antidepressants, benzodiazepines like Valium or Xanax. These things actually decrease anxiety, and it may be that tics decrease simply because the anxiety's been reduced. These are the biggest medicines that we got. These are the old ones: Pimozide, flufenazine, haloperidol. They make kids a little on the stiff side. Risperidone does a really nice job with tic suppression. It also is pretty good for explosive outbursts, impulsivity, those kinds of things. So you see a lot of kids with Tourette getting it because they have poor behavior control, poor mood, affective regulation kinds of stuff, and tics. And this kind of quiets them down, helps them fall asleep at night, decreases some of that instability in their behavior and moods, and can work pretty well. We're seeing a lot more kids being tried on Abilify. It's a limited data supporting its use. Just to give you an example, there were, I think, 40 to 60 kids, somewhere in that study, that one study that proved that Risperidol was useful, 40 to 60 kids. These are all smaller trials even. The Ziprasidone or Geodon study was actually, I think, under 40 kids and adults. So these are very small studies. The aripiprazole study hasn't even been published yet, to my knowledge. Tetra Benzene hasn't been done in Tourette, although there are many people who really like it. It's now available in the United States. It's pretty expensive. You see a lot of kids on Seroquel. Seroquel doesn't really do much for tics, but it does do more for sleep, and mood regulation, behavior control. So you'll see kids with Tourette, oftentimes milder symptoms on that, not because it's going to work on their tics, because it doesn't work very well for tics, but it does work pretty well on that kind of behavior and emotion control stuff. Olanzapine, probably no reason to use that because the doses that work on olanzapine tend to be the weight-gaining doses, so 10 to 15 milligrams. Some people can take this stuff without gaining weight, but the weight gain can be pretty impressive with this one. And this one has significant side effects, requires weekly blood monitoring. There's no reason to ever think about using that in Tourette. It's likely not to be effective, and it's got risks and management issues that are untenable. So these are our big guns for tic suppression. This is what we got. Botulinum toxin. If you're here at the conference and you hear somebody begin to talk like this a little bit, they may have had botulinum toxin for vocal tics, because what they do is they inject small amounts of botulinum toxin into the vocal cords in order to disrupt the vocal tic. It's single muscle usually, so if people have a tic that's like this that persists or they hold, they can inject the right muscle in the neck. It offers a mild paralysis. It lasts for 2 to 3 months. It's reversible, but not immediately reversible. So we've seen some folks who have had big, pronounced eye blinking where they did some in the eye muscles, and they'll develop a little lid lag simply because the paralysis is there. And it's not readily reversible. It takes time for that to kind of wash out. So this one really requires a specialist to do, and not for everybody. Brain surgery, you probably read a lot about deep brain stimulation. Before that, we did ablative procedures. That is, they would go in with a little kind of a electronic or laser knife and zap little portions of the brain. It was mostly done for people who had OCD, because this is a bona fide treatment for OCD. But as we know, some people with OCD also have tics, so the reports are really about what happened to the tics when they treated people for OCD. The results are pretty mixed. The deep brain stimulation, many newsworthy cases. Again, this is a place to go on YouTube. This is one place where you will see people who have Tourette syndrome who have undergone brain surgery, DBS. Many of them that I see, I have real questions about what their real diagnosis is. So I think we understand with many medical conditions that there are people who have a condition, and some people elaborate their condition, some people minimize their condition. Some people who have a condition have extra condition symptoms that are under more psychological control than under neurologic control. For example, we know that there are people who have epilepsy, but then they have non-epileptic seizures. They have movements that are not caused by epileptiform activity in the brain. And we see people who have Tourette syndrome, but also have movement problems that are extra Tourette. And it's very difficult to sort and sift through that. But it's an important distinction to make, because the last thing you want to be doing is deep brain stimulation on somebody whose movements are really caused by something other than kind of brain factors. This is really a bit of a history, and I'm not going to spend too much time. They use it for dystonia. Again, if you want to know why people are excited about deep brain stimulation, go look up childhood dystonia on YouTube, DBS and childhood dystonia. You will see kids. The first kid I saw, dystonia is where you have these chronic disabling muscle contractions, right? And the kid that I saw who got DBS, the first video I saw, her feet were curled under, so she actually walked on the top of her feet. Extremely painful. Upper spine was contorted. Unbelievable. She was wheelchair bound. She really couldn't walk because she couldn't weight bear. They did DBS on her. She was 15, 16, something like that. And they showed her about 9 months later, and she's walking with this kind of lovely little lilt. No cane or anything, but walking. Well, when you see that kind of physical change in a youngster, we didn't have any treatments for that condition, really. But DBS essentially saved her functional life. When you see stuff like that, you know why the neurosurgeons get excited about doing this procedure, because there can be times where it's absolutely miraculous. One of the manufacturers of these devices kind of does a life story of this old guy, shows him before he got deep brain stimulation, and then shows him walking in the park and dancing after deep brain stimulation. And the functional difference in that guy pre and post is pretty substantial. So those are the reasons why people get excited about this technology. The problem is that in some of these conditions, we know exactly where to go in the brain to implant the electrodes. We kind of don't really know where to go with Tourette, because we haven't really figured out where Tourette is. If you want to cause problems with train traffic in New York City, you can either go to Penn Station or Grand Central. So deep brain stimulation is a little like that. If you really want to affect anything that could possibly have anything to do with Tourette, then you go somewhere in the thalamus. And there's probably some better places within the thalamus than others. And so what you're seeing a lot of people doing is they're going to the thalamus, because it's the grand central station, or the Penn station, if you will, of the brain. And if you plant the electrodes in there, you'll affect more broadly brain circuits. So that's really what the idea is. The Tourette Syndrome Association has actually made recommendations for about who should get it, and also is trying to develop a registry so that we can get to learn from the cases that are being done sporadically. To date, there's no funded trial of DBS and Tourette, so the federal government hasn't invested in money in it. This is what the stimulator looks like. This is what the electrode looks like. When it's implanted, it looks like that. Most people with Tourette get 2. There are a few cases that are getting 4, because there are some spots in the brain that might be better for movement, and there might be some spots in the brain that are better for affective and behavior control kinds of issues. So it's a very complicated issue. I'm not going to spend too much time here. This is just for you all to know that it's a big deal to undergo this. But despite the fact that it's brain surgery, and there's a lot of post-operative care, this is something that has a relatively benign side effect profile. There's a little bit of risk during the surgical procedure, but after that, it's not so bad. So there's surgical risk, but it's amazing that you can take these things and thread it through the brain without causing a whole lot of trouble. Isn't that interesting? A lot of wasted space up there. Some targets have more risk than others. One of the early malfunctions was a guy who was a farmer and had DBS, and then went to work throwing big bales of hay, and all of that physical activity in his neck and upper body kind of broke the stuff. And every once in a while you see unintended impact on other brain regions. So you, like in Parkinson's disease, sometimes you see people have problems with gambling. So they begin to do risky behaviors when they get stimulated. And if it doesn't work, they are not excited about taking them out, because there's additional risk to take them out. So if you put them in and it doesn't work because you put it in the wrong place or whatever, you usually put more in, not take it out and replant, right? Because that's where the risk to the brain comes in, by mucking around in there. So they tend to put it in and then do more, or just leave them there if the patient's not interested or it doesn't work for them. That's why when you're talking about doing it in a kid, remember, you're talking about worst symptom severity is 15 and under, right? So if you got a kid with terrible Tourette at age 14 and you're thinking about doing this, in another 3 years he may have a marked reduction in his symptoms. But if this goes in his brain at age 14, this is going to be in there for a long time. So we have a variety of reasons why we're, we think that this is an important treatment to do research in, but we're not all that excited, because as compared to dystonia, we have a variety of other treatments that can be particularly effective. Most of the DBS that's being done in the United States is being done by surgeons to whom the patient is a stranger. So you'll hear about people flying from one part of the country to the Cleveland Clinic or to New York City or to Johns Hopkins, and they meet the patient for the first time, make an assessment, and decide, and may operate on them in that week. From my point of view, that may not be the soundest strategy, especially if there's not a lot of coordination between the referring doc and the surgeon. Especially if there are symptoms that are atypical or unusual, or other treatments haven't really been completely exhausted, and if they're under 18. So I think when you're having doctors doing surgery on young people's brains and they don't really know that young person or the family very well, there's some risk that you may operate on people where it's not really the right thing to do. So there's just lots of issues. Complementary and alternative, I get this all the time. So you'll hear about people who use nicotine, which actually is an agonist, which is a promoter of nicotine, if you will. And we've also used mecamylamine, which is not really available anymore, which is a nicotine antagonist. It is an unnicotine or an anti-nicotine. Both have been reported to work. It's probably dead as an issue. Although you'll hear people say things like, when I chew my gum or put the patch on, my tics are better. Or my patch plus my Risperdal work pretty well to control. And that's the anecdotal stuff that you were hearing a while back, but it just hasn't sorted itself out quite that way. Because of the marijuana piece, people have gotten very interested in both blockers of opiate system as well as using THC and other cannabinoids. People talk about hormones. There was a question earlier today in another forum wondering why boys have tics more, and there's some thought that maybe it's their sex hormones that, the androgens that may drive tic severity. So people have used anti-androgens to try and block that process. The problem is that system is so well conserved that any blockage of that system just gets overrun with more hormone. It's typically male. When less hormone is needed, what happens? They have more hormone. Omega-3, people are pushing this one hard, probably can't hurt. But there's so many different types now. It's really complicated. So be thoughtful about omega-3, but it probably isn't a terrible thing. So these are drugs you'll hear about that have what I call no legs. The people who did these studies don't use them. So if your doctor is using them, you're way, 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 way out on the end. So baclofen, Harvey may use that a little bit. The dose that Salih found, no one is using that dose, and Don Gilbert doesn't use pergolide anymore. Doesn't work. But in the studies, there was a little signal of some value. Pandas, oh my goodness. This is this whole idea that people develop tic symptoms or obsessive-compulsive symptoms in the context of a strep throat. And it's the idea that antibodies which are developed to fight the infection actually attack the brain, cause inflammation in certain brain parts, and that inflammation results in tics or obsessive-compulsive symptoms. But in order for you to have a diagnosed case, you have to kind of jump through a lot of hoops. Most of this diagnostic criteria was developed for research purposes. It was not, as I would say, empirically derived. They didn't take 1,000 tic disordered cases and identify a subset, right, who sorted into classic clinical presentation, who had all of these different things. They wanted to study this phenomena, so they made diagnostic criteria up so that they could include people in their studies. And it was all based on clinical observation. It was not based on any kind of scientific study. It was based on what people thought pandas might be. And the problem is we're kind of still there. It's kind of what people think pandas might be. This is Harvey Singer at Hopkins just wrote a nice new paper about childhood acute neuropsychiatric symptoms. There's a whole group of kids now, and we're beginning to understand them, who have a variety of neuropsychiatric symptoms, including onsets of epilepsy that appear to be infection-related. But the infectious agents are diverse. So some of it's viral, some of them are complicated intracellular organisms, some are traditional kind of bacteria like strep and as in pandas. But it's probably worth studying as a much broader issue, and the consequences may not just be tics and OCD. There may be anxiety, maybe seizures, maybe cognitive decline. There may be a whole kind of range of symptoms that may be infection triggered. So this is an active area of investigation, and so no one has been kind of doing this with as a tic-related thing. They're really broadening it from tics and OCD to kind of other neuropsychiatric manifestations. The bad and sad thing for me is that people are getting immune treatments, heavy-duty immune treatments, before we even know whether this is a validated condition or not. The one thing that is really important, and we keep seeing this happen, is that people will have new onset of tics and somebody will draw a strep titer. And a single strep titer is meaningless. But if it's high, all of a sudden it takes people and it carries them off into this pandas world. And the sad part about that is there may not necessarily be anything there for them, and especially if it's based on that blood level, because that blood level doesn't really have much to do with anything. Sequential blood levels may tell you something about a person, but a single one time is meaningless. So I don't do it. And when families tell me that they got a blood level back and it was high, I say, oh my gosh, you poor thing. I wish it had been low. Because if it was low, then we could forget about this. But now that it's high, I know that it just sits in this portion of your brain, and it just makes you worry and worry and worry. And you shouldn't really worry because it doesn't have a whole lot of meaning. So if you really are going to treat them, send them to the nationally recognized centers, so the NIH, Tanya Murphy in Florida. There are other people who are doing this. We don't treat elevated antibody titers. Why would you treat something that occurs 6 weeks after the infection is over? You treat sore throats. You treat skin infections. Impetigo is what I was thinking of. And please use conventional treatments, medication, and CBT for OCD, anxiety, Tourette, those kinds of things. Non-pharmacologic strategies for tics. Everybody ready? What do we know about tics in the environment? Well, excitement. Disneyland is the worst. How many have taken your kid to Disneyland? How bad was it? That's really bad. So this is the general story. So the kid has onset, let's say in November, right? Everybody's shocked. He's 8 years old. They get the diagnosis. They had to wait 8 weeks for the appointment. They read all kinds of junk on the internet. Oh, my God, that's so full of worry. The whole house is just walking on eggs. The kid's looking around like, what the heck happened here? My family's in it. Then the school doesn't understand, and so then you get somebody to go to the school, and the school is beginning to push back a little bit because that's what schools do. So the family is like, oh my gosh, and then they go out to YouTube and they see the worst cases, and they read about deep brain stimulation. Oh, but they finally get through the year in May, early June, and they say, you know what? Our family deserves a treat. We're going to go to Disneyland. He's always wanted to go to Disneyland. Oh, my goodness. They get so excited there, their tics just explode. Fishing, okay? Fishing is what you do. And if you're really smart about it, fish in a lake where there aren't any fish, so there's no chance that he'll get excited about catching a fish. They also get worse with stress. So before a test or before some kind of performance or something like that, the tics will go up. They also get worse with fatigue. So families that do homework after dinner, they're going to run into a kid getting tired, and when they get tired, their tics are going to get worse. Paying attention to tics, asking about them, talking about it, engaging a person about their tics makes tics worse. So we've turned that into ignore tics. But we really now don't mean ignore tics in quite the same way as we used to. So I'll explain that in just a second. The other thing is a free-to-tic environment. One of the things that we've told families is you should make your home a free-to-tic environment. I'm not so sure that's what we really mean to say. I think we want an accepting environment of tics. But I don't necessarily think we want to have a free-to-tic environment. And I'll talk about that in just a little sec, because it's subtle, right? Subtle. Tic improvement. We love calm, focused activities. Fishing. You'll hear about biofeedback, deep relaxation, hypnosis, self-hypnosis. You'll hear about a variety of these kinds of things being effective for some people. All of those strategies take people's brain to a calm, focused place. So I've tried to do deep progressive muscle relaxation, which is, you scrunch your toes, let go, scrunch your calves, let go, scrunch your thighs. You scrunch all the way from the bottom to the top at a way to kind of really loosen yourself. I've tried doing that with 9-year-old ADHD boys. Not an easy thing to do. But it gets easier if you say, listen, I want your brain to get to a quiet place. We're not just scrunching toes to scrunch toes. We're trying to do, through this procedure, get your brain to a particular quiet place. Met another adult with Tourette who learned about this, idiosyncratically and kind of on his own. And what he describes is when he's in a social situation, his tics pick up. So he's meeting new people, he's socializing, that's unexpected kinds of interactions, laughing, jokes, all kinds of stuff. A little bit of a kind of social embarrassment maybe. And he says that when his tics begin to rev up, he can put himself relatively quickly into a calm mental state, and his tics just dissipate. So he's a musician, so he, when he's playing, and in the midst of playing, he goes into that zone too. Athletes know how to get themselves into that zone. So what we're talking about now when we're working with children, it's not just to do relaxation. It is to do relaxation to put your mind in that quiet zone. And you can get there with fishing. You can get there watching TV. You can get there with video games. Now, as soon as you're taken to a new level on the video game, you are no longer in that calm, focused activity. You have energy and aggression and excitement, and the tics may accelerate. That's why you see some kids do very well with video games and some kids do terrible with video games. But we want that brain as much as possible to be in that zone. And it requires action and activity. People have said, why do kids, have their tics explode after school? They used to say, well, it's because he sat on his tics and controlled them all day. They were involved in focused activities at school, and when they're involved in focused activities, their tics go down. When they come home and they're blowing off steam and there's nothing to do and there's no structured activity and they aren't given a fishing pole and told to go out to the lake, what will happen is their tics will rise and explode because they're overstimulated, understructured, they're not involved in a calm, focused activity. They're in an exciting time of the day, a blow-off steam time of the day. You would expect that their tics would get worse after school, not because they were holding them back, but because their mental state changed. So when I work with families about after-school activities, I work about them to get them involved in pleasurable activities that are calm and focused, and work on that transition from school into calm, focused activities after school so that brain stays quiet. See what I'm saying? That's not a tic-free environment. That is an environment that is focusing on activities that aid kids in managing their tic severity by helping them get to mental places where they will have fewer tics. Does that make sense? A lot of families say, he has to get rid of all the tics he's held back all day, so I just kind of let him go. And that's not what we're talking about. We're talking about keeping them in that calm mental state as long as you possibly can. There's no harm being done with that one. Physical exercise is generally pretty good for tics. Plus, if you think about what you see baseball players with tics do, before the play starts, they stop ticking. Well, everybody's kind of... That's what happens to baseball players. When they're in the calm, focused activity of baseball, their tics go away. When they're between plays or between pitches or something else, they have extraneous movement because they're excited. But once they're settled and focused, a lot of people worry about driving in Tourette. I worry a little bit more about anxiety and panic with driving than I do about Tourette, because when people are focused on kind of keeping the car in the line, it's a kind of a zone experience. So anytime you can help your kid get into that mental zone, that's going to be good for tic suppression. And as an adult, finding strategies to do deep muscle relaxation or biofeedback or whatever you want to call it, self-hypnosis, those kinds of strategies that quiet your brain will give you some relief from tic severity. Inhibiting environments. So this is what I'm talking about with an inhibiting environment. This is not a shaming, don't stop, you have to... That's not what we're talking about. We're talking about setting up the environment in such a way that allows the youngster to get deeply engrossed in activities, to be successful with those activities, to get to that zone brain space, if you will. And then we've heard so many adult stories about things that they have done to kind of manage their tic severity. All of them are consistent with kind of the behavioral theory which underlies this treatment. Okay, so here's the theoretical model. So the first tic, the kid doesn't notice, and neither does the parent or the school teacher. The second, third, fourth, fifth, sixth, seventh, eighth, ninth, 10th. Okay, all of a sudden people are beginning to catch on. The kid notices that he keeps doing this thing over, and now the teacher is saying, why is he doing that? Then the teacher calls the parent and said, have you noticed he's doing that thing with his head? I told him to stop, and he wouldn't stop. And the parent says, yes, we've noticed it too. Let's ignore it. And then he keeps doing it. And the other kids are asking him, why do you move your head like that? Well, all of a sudden what's happening is this youngster has having this experience, which is uncomfortable at least. It may be painful, but at least it's interpersonally uncomfortable. Begins to recognize that it happens here, it happens there, can't necessarily control it. Begins to kind of do this internal focus on kind of where that is, what makes it better, what makes it worse, why am I doing this? The people look at him, point at him, stare at him. And so you begin to create this dynamic where the next logical thing for the person to do is to begin to try and anticipate when the tick will happen. So there are some of us that actually believe that that premonitory sensation or urge, that sensation that occurs prior to the tick, is not tied to the tick, but is secondary to having had ticks, and a natural kind of thing that human beings do to try and figure it out and to anticipate when the tick will occur. We actually see some ticks on EEG that look like they are just motor movement, just a flash of motor movement. We see some other ticks that actually look like they have a thought or some kind of cognition or some other experience, maybe the sensory phenomena, just before the tick. But not all ticks have that. But if there is a sensation, and you'll hear people say, I get this feeling in my shoulder, this itch or this heat or something, and I know that if I roll my shoulder 3 times, it'll make that go away. That whole process of feeling it in your shoulder and doing it 3 times to make it go away, are you ready? Reinforces that tick and makes it more likely that the next time anything is touching that shoulder or affecting that shoulder, that the response will be 3. Now, if it doesn't go away to 3, it may go to 4, it may go to 5, and you can begin to see how management of tics in response to this sensation or this urge can, over time, become behaviorally elaborated. We're not denying that the tic's real. We just know that human beings, when they have an itch, they scratch. And when they have a sensation and a tic disorder, they're more than likely to do something to try and make that sensation or that discomfort go away. If that movement makes that discomfort go away, that movement is reinforced, right? So the behavioral treatment is trying to disrupt that. It is trying to look at that sensation and the tic and kind of decouple them. Does that make sense? So the way that we decouple them is when the sensation is there, we ask somebody to do something different other than the tic until that sensation goes away, or you do it for a minute or so. So the first kid I saw demonstrated, and I think he's a really good example about how the tic works. He had a woo-woo, woo-woo, woo-woo. That was his tic. Wow, that's going to be fun. And he was doing it often, 1-2 times a minute in the demonstration setting. So the guy said, well, do you have an urge to do this before? And he said, nah. And he was like 12 or 13, old enough to know, kids report that urge starting about age 10. They don't report it at 6, 7, and 8. So it was like, oh my God, what's he going to do? He doesn't have an urge. How's he going to work on this? So he said, well, how do you know to get your hand in front of your mouth before you go woo-woo? Remember, it was woo-woo, woo-woo. It wasn't woo-woo, right? So the therapist picked up that there was something happening in the hand before the sound. So what did the therapist say? This kid was doing what I call white-knuckle tic suppression. Trying as much as he possibly could to control the muscles in his face so he didn't make the sound. And you'll see patients with Tourette do that. Sometimes their bodies are so rigid because they've just tensed everything to kind of control them. So that tics are all kind of muted because they're just trying to exert that control. I call that white knuckle suppression. It doesn't work, actually makes it worse. But what the therapist said is, I just want you, when your tics get worse or when you think they're going to get worse, like when do they get worse? Well, whenever I head into school just before my first class, my tics are always worse because I'm kind of both excited and a little nervous. And he said, well, I want you to focus not so much on the woo-woo sound, but I want you to focus on the movement of that hand. So you know that you're going to be ticking more when you go to school. So what I want you to do is focus on the movement of that hand and just think about your hand. Well, guess what? Thinking about your hand is a non-white knuckle tic suppression strategy that requires, guess what? Calm, focused attention. Cool, huh? Then he says, I want you to diaphragmatically breathe. You guys know what diaphragmatic breathing is? Most of us inhale like this. We suck our tummy in. Diaphragmatic breathing is yoga-style breathing where you push your stomach out. You make a conscious effort to push your abdominal wall out. Your diaphragm drops, and your lungs fill kind of passively. You're not using chest muscles. You're using abdominal muscles. So think about your hand and focus on getting into a rhythmic diaphragmatic breathing, which is also a calm, focused activity. Pretty cool, huh? So now what we've done is we've taken this guy in an inconspicuous way, given him two things that he can do that will put his mind in a calm, focused activity, focusing on something not tic-related and not conspicuous, and then doing an activity that really requires motor movement until that sensation or until that hand is quietly back in its pocket or resting at his side. Over the course of the 20-minute session, you saw the tic actually go down. So that's what the treatment does. It's taking advantage of brain states, if you will, using specific techniques around specific tics, that mental state where they feel like they're calmer and more comfortable. Another one, this is one of my favorites. I love this treatment for doctors because it's it's a dumb treatment suitable for most physicians. I had a 6-year-old. His solution was classic 6. He stuffed his whole hand in his mouth. Cute as cute can be. Came in the office with his hand in his mouth. And they didn't care about the tic at school. It was, Billy, get your hand out of your mouth. Get your hand out of your mouth. Don't put your hand in your mouth. Get your hand out of your mouth. Get your hand out of your mouth. The kid was a nervous wreck. So I said, oh, geez, can we just do this? Can you, instead of putting your hand in your mouth, can you just go like this? Cover your mouth like you were belching or coughing or something like that, and then press your tongue right up against the fat part of the finger until you feel like you don't have the tongue thrust anymore. So he said, sure. You can walk around all day like this. You can't walk around all day like that. So that's what he did. And what happened is the teachers didn't yell at him anymore. He was sitting in class. He found himself to feel more, his 6, confident, comfortable. Nobody was yelling at him. He knew what he had to do. His parents were supporting him using this at home when he was doing the tic at home. And that tic faded after a week, 10 days. Might have gone away anyway. Got what I'm saying? Who knows with that particular tic? But this kid felt really good about doing what he's doing. And we took him out of a situation where he might otherwise have had a medication trial to try and suppress that tic. Plus, my experience with medication for those kinds of tics, it'll quiet the frequency of eye blinks, but it won't necessarily handle a complex tic, where complex tics can be broken up into these pieces, like the woo-woo thing that had a hand component to it, a sound component to it. When I see a complicated tic, I almost get excited about the behavioral treatment because there are many places where I can intervene with a competing response. Does that make sense? Eye blinks are tough. They're over before they even start. Much tougher symptom, but it's also a symptom I don't care much about. It rarely is impairing the sounds and the other kinds of things. So talked to somebody this morning about coprolalia. Chasing coprolalia with medicines is really tough to do. The behavioral treatment sets itself up very nicely. You use diaphragmatic breathing as the competing response for coprolalia. You know, we said forget about your tics, ignore your tics, don't pay any attention to them, don't think about them. That's the old advice. But now we're saying, study your tics. What makes them better? What makes them worse? When are you doing it? You know, is there a peculiar one or a special one, or do you save it this way, or do they ever come in bouts? Break it up, figure it out, and then we'll figure out a strategy to kind of manage and sculpt your tics so that you can be more comfortable in more places with your tics.